Sorry, I'm not very good at this. Okay, so anyway, the drug manufacturers were offered the opportunity, if we agree to buy a certain amount of these drugs from you for a 10-year period, will you sell them at a lower price? Okay, they then sell the drugs at a lower price, either to NGOs or to the government, and that way the benefits are distributed to individuals in the countries, in the form of lower priced drugs. Okay, and here it shows the dramatic effect. It used to cost $6 to $10 to buy these combinations. Because of the market commitment, the large scale, the drug manufacturers agreed to a much lower price, and then again the international agencies gave a further subsidy such the cost went to 5 cents per person, and it made these new better drugs affordable and competitive with chlorquinine, these old drugs that are cheap but not highly successful. The first 2 countries already received these combinations in August 2010, and probably since then it's been expanded in sub-Saharan Africa. A somewhat similar mechanism was used by the Global Alliance on Vaccines and Immunization in the form of an advance market commitment to reduce vaccine costs. It's been first applied to pneumococcus vaccine. There is the intention to extend it to rotavirus, and I think ultimately people are hoping for a malaria vaccine. But they tried it out, something that was easier to get started, even though in the long run probably the goal is malaria. Okay, and again you can see a lot of players involved: WHO, UNICEF, manufacturers, developing countries, the Global Fund providing financing. It's a very complicated arrangement, but it's been successful. The first vaccines came out, I think it was in 2010. Sudan is one of the countries that has rolled out this pneumococcus vaccine, and the aim is to spread it throughout sub-Saharan Africa and then to introduce rotavirus vaccines. Okay, and then the last mechanism that's been used in health has been to issue prizes, so-called grand challenges, to encourage researchers to tackle big issues in international health that have not received enough attention. Okay, and it's a mechanism that's ongoing. So could this be used for nutrition? Could advanced market commitments or prizes help to spur on and make interventions in nutrition more widely available and more affordable? Okay, you can imagine for micronutrients, for fortified foods, for specific complementary foods, and for ready-to-use therapeutic foods, it's possible maybe to use these mechanisms. So where are we? How can this go forward? I was lucky to be invited to one of the side meetings at the recent UN high-level meeting on nutrition, which was held in New York just this recent September. And here you'll see Ban Ki-moon and also Hillary Clinton speaking in a panel. And it was fantastic to have nutrition on the agenda for this very high-level meeting. There are other encouraging developments. There are donors who are now prioritizing nutrition. Okay, Ireland, which examines all its development projects through a hunger lens. Similarly, the UK is spending more on nutrition and is launching nutrition projects, and other donors are following suit. Okay, obviously the G20 is important. There is a meeting coming up next month in Cannes of the G20 group, which has a committee on agriculture and nutrition. Okay, so there are discussions ongoing about having some announcements about nutrition to come out of this Cannes meeting along the lines of things that have been done in health. And in some part, the 2008 food crisis helped to focus people's attention back again on food and nutrition that had dwindled, following the years after the 1970 food crisis. This will be tremendously important towards achieving the Millennium Development Goals. Nutrition is important not just for the hunger goal, but also the mortality goal. And just to summarize, nutrition investments are effective, they're cost effective, we can afford them, and something is being done. So thank you for your attention.
Thank you, Dr.Sue HORTON, for this comprehensive lecture on the benefit-cost ratio of interventions and how interventions like food fortification and micronutrient supplementation are efficient and they are cost-effective. And I want to remind our participants that we will have a workshop on salt iodization on Sunday to discuss this issue. It's also interesting to see now the high-level leaders and politicians committing to support nutrition interventions. And on the same line, the last UN General Assembly, where leaders declared that they are supporting nutrition intervention because they recognize maternal and child malnutrition affects adults' health and particularly communicable diseases. We have 5 minutes for discussion, so the floor is to the audience. Any questions? Yes, Mohammed Mansour.
That's okay, I can shout. Dr. Horton, in relation to the next Copenhagen Olympics, as you put it, in 2012, I have two specific questions. One is, would the same economist participate in the next? And would there be any conflict of interest or vested interest in having the same ones? And the second point is probably more important, is what would be the influence of the debate that was recently led by late Dr. Michael Latham about vitamin A supplementation and its debatable effect on morbidity and mortality? Thank you.
Okay, so I was actually approached to ask if I would participate in the 2012 consensus, but my view was it was better that someone new would do the analysis and perhaps bring new ideas, fresh ideas, and maybe evaluate new nutrition interventions. I did not participate in the 2004 consensus, and I think, fresh ideas are important. So I'm not sure, actually, who is doing this. I will be interested to find out. And on the second question about vitamin A, so what's being said is that vitamin A, in the early 1990s was extremely important in an environment where measles immunization was not comprehensive. But subsequently, as measles immunization has become more widespread, then the additional benefit conferred by vitamin A supplementation is likely smaller, because the mortality risks are lower. So I think that would be my understanding of what's happened. Does that mean we should stop vitamin A supplementation? I think we should think about the level of infection in the country before we would decide that. It may reduce the emphasis on vitamin A. We may prefer to focus in countries where infections are still much more prevalent, and the vitamin A is the way to go. But clearly, in the long run, having foods rich in vitamin A is important irrespective of the country. Thank you.
So I'm Izzuddin. I'll be happy to interact with you on Sunday. This is a very interesting, actually, and a very supportive interaction with the fortification issues. My concern is this: when the research is advancing, then we have some problem coming up, like, for instance, salt. You have the campaign now going on salt reduction. And I wonder whether such factors is being considered when you're doing a costing methodology, and how this will affect, or for instance, those endemic area where iodization is going there, or excessive intake, or vitamin excess intake, how this will affect, you know, the such, thank you.
That's a great question, and we're lucky that here we have an expert who was at the WHO in the middle of those debates, Dr. Bruno de Benoit, who is also on the program. And the short answer, I believe, is this. We all need a certain amount of salt, okay? And it's not bad if that salt is additionally fortified with something that's very beneficial. Equally, we don't want to consume too much salt. So it's possible to increase the fortification level on the salt so people get enough, and encourage people to consume less salt, okay? But at the same time, we can also think about other vehicles for fortification. I had an interesting discussion at breakfast on fortification of oil with iodine, which is being promoted as an alternative. And same thing, again, we all need a certain amount of fats in our diet. We don't need too much, but there is no reason we can't use oil as a fortificant. And, you know, same thing, we can also fortify flour with things like vitamin D. You know, so I think there is no conflict between the nutrition and the health benefits here.
Of sodium for the purpose of improved chronic disease, let's say reduction of hypertension, does not need, as you were saying, to compromise the iodization. In fact, those calculations are available in the A2C website, and Omar Dari has done it for every country in the world. You can calculate how much more iodine you need to add as you monitor sodium intake. So it's very important that we do not confuse the reduction of the chronic disease issues with getting rid of malnutrition. They are not in conflict. They are in fact complementary. So this is a very important point, especially for this region, as it relates also to other fortifications.